शेयरिंग इनेबल नहीं किया उनका।
Good afternoon, friends. It's 3 o'clock, and we are back with one another episode of our Forefront of Future Frontiers, the FFF webinars. We started way back when the COVID started in the month of May, and we are very happy to see that we have completed series and 23 talks, and this would be our 24th consecutive talk. We've been doing it continuously every week on Fridays, except the last week, which was Gandhi Jayanti. There was a national holiday. So that is what we have been going. And our purpose for starting this webinar series is organized by the Scientific Society of Aarupadai Veedu Medical College, Constituent College of Vinayaka Missions Deemed Research Foundation University. Our primary purpose of starting this webinar was to bring therapeutics, diagnostics, advances in education and healthcare currently in the realm of only elite few into everybody. So that was the main purpose with which we started. And we are very happy to see that we started with initially series 1. We had 6 talks, which was all about recent advances in healthcare. Then we moved on to series 2, where we spoke about how COVID has impacted healthcare as well as education. We moved on to series 3, where we talked about how we can overcome these impairments caused by COVID. And then in COVID 4, which has been our longest series so far, we had almost 8 talks about 4 frontiers of research. So what is all going in, starting from genomics to moving into personalized medicine and drugs. And also we spoke about the clinical trials which are happening in COVID. We spoke about diabetes and how it is affecting COVID. So all these variety of topics. And we are very happy to see that our resource persons included people from across continents, as well as from reputed speakers, a lot of them from India also. So the last talk was on qualitative research, what can be done in healthcare and medicine, and that was by Dr. Amol Dangre. This is a brief overview about what we have been trying to do for the last 24 weeks. I welcome you all for this session for today's talk. And I would request our Dean Sir, Professor P.F. Kotur, to introduce the speaker and to welcome the gathering. Over to you, sir.
Yeah, thank you, Professor Mahalakshmi. As the head of the institution, I have the honor of welcoming all the participants, including the resource person, Dr. Shivaprasad S Goudar. We have eminent directors of research of our university. We have director of research of AVMC and other HODs, faculty members, and even the guests from the other institutions. I take this opportunity of welcoming you all on behalf of our management, on behalf of our Honorable Chancellor and University at large to this webinar. And as already said by Professor Mahalakshmi, this FFF online platform, which was created almost 6 months back, more than 6 months back, and during the time when we all were totally disturbed and confined to the 4 walls, knowing not what to do, the platform hosted eminent scholars, as already said, eminent teachers, eminent scientists, eminent researchers across the globe. And in no time, the platform earned the credibility, which is evident by the feedbacks received, which is evident by the number of participations in each of these webinars. And many of the topics, as already said, are quite relevant to the condition of the COVID pandemic. It was addressed from all different perspectives, different facets. And now, after this pandemic, now we are convinced that this is going to continue for some uncertain period of time. Nobody has got an answer how long this COVID is going to continue.
The person you are speaking with has put your call on hold. Please stay on the line. நீங்கள் பேசும் நபர் உங்கள் அழைப்பை ஹோல்டில் வைத்துள்ளார். दयவு செய்து लाइनिल कातिरुक्कवुम. आप जिस व्यक्ति से बात कर रहे हैं उसने आपकी कॉल को होल्ड पर रखा है. कृपया लाइन पर बने रहें. The person you are speaking with has put your call on.
Malakshmi, whose phone is that?
No, I don't know. Some participant, I think. I'm not very sure.
Because I was wondering my okay, anyway.
Phone. Yeah. Sorry.
No, it is not my
participant.
Phone. Yeah. I'm very sorry. Yeah. So I said already many of the topics were relevant to that situation, and now after realizing that the period of this COVID pandemic is going to continue, and we have to learn to live, or have already learned to live with it. And these why I said certain is as per today's statistics, about 36 million people are affected across the world, and out of which 20% are from India, 1/5 of that. And one good thing is, India contributes only for the 10% of the total deaths. So, and now I said, that's why I said we have learned to live with it. And now slowly we are trying to come back, or struggling to come back to normalcy. In due course of time, the colleges, schools are going to be open now. And we have to resume our earlier, we are eagerly expecting the directions from the regulating council to resume. Now, with this much of background, our university from the beginning, from the beginning of this year or the last year has been very much geared to address or promote the research at all levels and all the constituent colleges. And the eminent researchers, eminent scholars have been inducted into the family of the AVMC or VMRF, and the management has also pumped in a lot of money into the research, so that research is promoted, research is encouraged at all levels by the staff and students. In such a scenario, the effort of this AVMC in organizing this, continue to organize this FFF webinar, it certainly be a contribution from our constituent unit to the university's goal. And I must compliment the scientific society for choosing today's speaker, resource person, Dr. Goudar, who is an ardent researcher, and who will be sharing his first-hand experiences in his research journey of more than 3 decades. And I'm sure the staff and students of our institution and all the participants also will be benefited by first-hand information of the journey of the research. With this much of some of these thoughts, I have the honor of introducing today's resource person, Dr. Shivaprasad Goudar, whom I'm proud to say that he's one of my very good friends. And both of us almost joined the institution during almost the same time, a year before or less. And both of us have grown together, And Goudar, to start with, like of us, like me, I was also a passionate teacher of physiology. And I have personally seen him, or I'm a witness for his metamorphosis from a teacher into a medical educationist and into a researcher of international repute to this today. I'm the first-hand witness of this. Everything happened in front of my eyes. And for some of the things, I was a part also. Now, sorry. I'm just recollecting our journey almost 3 years back when our university had tied up at University of Illinois, Chicago, and all of us were made to go to Chicago for undergoing various fields. This is how Goudar was introduced to education. I was introduced to education, medical education, and we had a decade-long collaboration with the University of Illinois, and the Department of Medical Education of Yale University was built, and now today is one of the nodal centers in the medical education under our regulating council. In fact, we venture to get recognized as the first academic staff college of the medical education in the country, by virtue of the disadvantage of being a deemed university. We could not do that, otherwise it was almost done. This is about education. Then after about more than one and a half decades, way back in 2000, beginning of the 2000, Dr. Goudar started getting more involved. He was introduced to research in the University of Illinois, and he caught a string, and probably it was a hidden talent in him to be a researcher, and he inclined and he developed himself into a full-time researcher. That was the time, I left out my anesthesia and started entering this administrative field. And I aimed a different route. But being an administrator of Yale University for 7 long years, as a registrar, I saw him. I saw the research unit, how he groomed, how he developed. I'm very sorry. And that too, he himself being a physiologist in a university wherein all other branches, including pediatrics, including the obstetrics, which are in a full-fledged PG or post-doctoral departments, he proved himself to be a great researcher in the field of maternity and child health. See, that means the commitment, dedication has to be so much, And in just one sentence, if I want to tell him that he has brought our Parent Institute in the city of Belgaum in the international map of this maternity and child health, and which we will be saying in some of these slides. It's really well. And he's a role model, how a simple teacher and from a small place can get recognized as an educationist. And I must also say that I've gone to participate in the South African continent for one of the academic activities. When I projected my slide first in my talk, and when the name Jain Medical College was learned, one of the participants stood up, "Oh, you are from Dr. Goudar's institute." I'm talking about 25 years back. And he said, "Oh, Goudar is a phenomenon." This was the one African lady open-heartedly before I started my talk. And I used to pull his legs every time. "Goudar, you are a phenomenon. You are a phenomenon." And I don't know whether he likes it or not, but I still do go on doing that. This is about my personal experiences with Dr. Goudar. Now, coming to this ritual of introducing him, I already said he's a physiologist, and he was the first MHPE, Master of Health Profession Education, from the state of Karnataka, rather from India, also from UIC. And in fact, we wanted to develop our institute into a South Asian center for the Department of Medical Education of University of Illinois, which is the oldest medical education department in the world. And he is from my same alma mater, my college, Karnataka Medical College, both MBBS, MD. And next one, Mahalakshmi. And he has got additional fellowships and fellowship in medical education, of course, from I already said that. And he has a specialty training in radio immunoassay and clinical applications, Isotope Bhabha Atomic Research Center, Mumbai. Next one. And his accomplishments, till this day, he has 30 funded projects to his credit, 34 international presentations, 37 national presentations. His scientific publications exceed number 230, and he has about nearly 38,000 regular reads, and citations are 5,644. Next one. Yeah, and he has the prestigious Newton Prize for Research Excellence Award, by Institute by Newton and Bhabha Fund. It's a great honor for him and also for the institute. And he has the SS Paintal Award by the Association of Physicians of India. Our university, our institution, our sponsoring society recognized him as a teacher of the teachers. And he also has the BL Gupta Prize in Medical Education Technology. And he has a J.N. Maitra Memorial Oration by the Physiological Society of India, and he's the elected member of the American Pediatric Society. There's unique distinction for a non-pediatrician. Next one. Professor Mark, next one. Yeah, and yes, I have amongst these several publications. I have chosen about the first one, a prominent one, some 8-10, so next to 2-3 slides. These are the glimpses of his research activities till date, most recent ones. He's either a principal investigator or a co-principal investigator. In that case, the principal investigator is from outside India. So he's a co-principal investigator for this limiting adverse birth outcome, and this is a labor study, the acronym L, limiting adverse birth, like that, and funded by Bill Melinda Gates Foundation, which is ongoing process, and we about to have over. And another principal investigator for a study funded by Global Network for Women's and Child Health Research of Eunice Kennedy Silver, NICHD USA. And that also is going on until April 22nd. You can see all of these are for the focus area of maternal and child health in the area. Next one. And he's a principal investigator for low birth weight infant, another study funded by Bill Melinda Foundation, which is about to be concluded probably this month. And he's a principal investigator for Cradle 4 studies, again by the King's College London and UK Medical Research Council and Department of Biotechnology, Government of India. Previous one, Mahalakshmi. Previous slide. Can you go to the yeah.
Cradle, and next to that is
yeah. And
PJU JNMC.
And he is the principal investigator for another study, again with Bill Melinda, which is going to be concluded in 2020. He's a senior foreign investigator for this Thomas Jefferson University, another funded project, which is going to be till the 2023. Next one. Next one, please. Yeah.
So this is number 6 onwards.
Yeah, it is not changed in me. It's still 5. Slide has not changed.
So far as it has changed. Number 6.
No, now it is changed. There must be a latent period, I think, between you and me. Okay. He's another one, 7th one, the co-investigator for another breastfeeding education and Fogart International Center, very famous study, again concluded last year, I believe. And he's a director for the WHO center, in our institution. He's a principal investigator for WHO action studies, Action 1 trial, Action 2 trial. I think Action 3 trial also he has a comment funded by World Health Organization. The next one, I think another 2 are there. Yeah. Yes. Next one, Mahalakshmi, it's not changing.
It already changed. Co-investigator for aspirin supplementation of pregnancy-induced risk reduction.
The slide is not there. Yes. Then
of Women's Health Research of NICHD.
Yeah.
The principal investigator for evaluation and introduction of novel device in the management of hypertension and shock in pregnancy in low resource settings in collaboration with the King's College London. He is the principal investigator from research proposal trial preventing postpartum hemorrhage of the Department of Reproductive Health Research, WHO.
Yes. Yeah, the next one.
So slides.
So one thing introduction. One thing what I learned is the Cisco Webex platform. When the host is changing the slide, the participants may not see steady or there is a lag. This is what I realized now. Oh, the way why I purposely went into the details of these studies are one and foremost thing is they are all currently going on, and and which are possible in a place where we always say facilities are not there. We always say this is not there, that is not there. A small place like Belgaum, when we started humbly, that time we didn't have even air connectivity. In such a situation, these all things have. That means whenever there is a dedication and commitment, and certainly. And already I invited him. He is involved in many multicentric trials, multicentric studies. I requested him, if possible, to explore the possibility of involving our university also. I think this invitation my wife has given to him because it's that area. Okay, with these few words now. Yeah, I'll over to you, Mahalakshmi. Or shall I ask Goudar to take over?
Thank you very much for that introduction, sir. Dr. Goudar, welcome to FFF. The floor is yours. I made you the presenter, sir. Please go ahead. We are eagerly waiting for your talk.
Yeah, thank you so much for that very elaborate introductions. I don't think I'm either a phenomena or someone who's I'm just a teacher still, and I've sort of evolved as a researcher over the years. So it's actually a privilege to be participating in this session. So so can everyone see my screen?
Yes, yes.
So I and Dr. Kotur go a long way back, and we almost started our journey together in JNMC in the early 1990s. I joined in 1989, and I think Dr. Kotur also joined around the same time. And that was the time when the medical education unit was activated in JNMC, and we got involved in its activities. And it's been a long and a very eventful journey since then. And I can share any number of anecdotes about the kind of activity that we have been involved in, as well as some of the fun that we have had over the years. And so thank you, sir, for giving me this opportunity to share some of the work that I've been involved in as part of the Women's and Children's Health Research Unit at JN Medical College, Belgaum. So at this outset, I bring greetings to you all from my Chancellor, Dr. Prabhakar Kore, the staff and faculty of JN Medical College, as well as KLE Academy of Higher Education and Research in Belgaum. I thought we are in the northwest corner of Karnataka, and diagonally across to the other coast in down south is where you all are in Puducherry. So I thought I'll give you a brief introduction of our organization to begin with, just a couple of minutes, and then get to my actual presentation. So the JN Medical College actually belongs to a larger trust called the Karnataka Lingayat Education Society, which is more than 100 years old, established in 1916, and we have over 270 institutions across Karnataka, Maharashtra. We have a school in Delhi as well, and our institutions spread right from kindergarten to the postdoctoral level, and virtually every field of education, whether it's medicine, health sciences, engineering, technology, the traditional graduate colleges, degree colleges, in all specialties, in all disciplines. So right from kindergarten to the postdoctoral level. And I think what is really touching is that this whole endeavor was started by 7 teachers and 3 philanthropists in 1916. And they started out with a single Anglo-vernacular school in those days under the British Raj. And I don't think anyone would have conceived that it would go into such a gigantic organization over the last 100 years or more. and we had the honor of welcoming our Honorable Prime Minister for the centenary celebration. It was a special occasion for all of us. And it's not very common that the Prime Minister attends private functions, so we were really fortunate to have him for this special occasion. As far as my parent sort of institute, JN Medical College, is concerned, this is one of the oldest private medical colleges in the country, probably the third after CMC Vellore and KMC Manipal. It was established in 1963. As a university, we came into existence in April 2006. Initially, only the medical and dental colleges were there. Now we have 9 institutes encompassing, including Ayurveda, pharmacy, nursing, physiotherapy, as well as a new homeopathic medical college that has come into existence a couple of years ago. So that's who we are in the northwest part of Karnataka. We are just off the coast of Goa. So over the next 35 minutes, what I'll try to share with you all is sort of my journey in this whole area of maternal and newborn health research. As Professor Kotu mentioned in his introductory remarks, this whole thing started way back in 2001 when we were working with the University of Illinois having an academic collaboration, and that's when an RFA came out from the NICHD. NICHD typically funds, or the NIH per se, typically funds mostly domestic projects, at least in those days. This is probably the first time that there was an attempt to establish research infrastructure, develop scientific capacity, especially in third world countries. Of course, the final overall aim is to improve the health outcomes of pregnant women and young children. And the network was co-funded by the Gates Foundation in the first couple of years. And later on, of course, NICHD continued to support it. Now we are again getting some supplementary funding from Gates Foundation. We are right now in the fourth cycle of funding, starting in 2018 and going to 2023. And unlike most research grants, this is a center grant. Most research grants are protocols, but the idea of the global network is to basically fund a center, and then the center should develop scientific capacity and go beyond the protocols developed by the network itself to implement trials and establish research collaborations with other universities and other funding agencies. And that's precisely what has happened in the last almost 20 years of our existence. And last year, in fact, we got the recognition from the WHO as the Collaborating Center for Research in Maternal and Perinatal Health. This is right now for a period of 4 years, renewable based on performance. In the last 19 years or so, we have completed 24 major protocols. 13 are ongoing now at different phases, right from conception, just getting funded, to those which are almost on the verge of publishing the primary paper and close out. 2 are in the pipeline, which should be up and running in the next 2 or 3 months. Corona or no corona, I think life and research has to go on, and that's basically what the philosophy that we have also adopted, that learn to live with corona. So right from the time the first unlock was announced by the Ministry of Home Affairs in May, we have been back to work, and all our protocols are in the field actively collecting data. So we are back to almost full normal functioning. One of the longest running protocols that we have been involved in is the Maternal Newborn Health Registry, which is a population-based registry that is maintained in all of the global network sites in both Asia, Africa, and Central America. It started in May 2008, so we have already been 12 years into the existence of this registry, and we have almost 750,000 pregnancies in our database over the last 12 years. And there's another site in Nagpur in the NICHT Global Network. So between the two of us, we have almost 40%. That's about 270,000 of the 750 pregnancies in the database. And what's really unique is, and this is real credit to the the PHC staff, the ASHA workers, the ANMs, and the PHC medical officer, that we have almost 100% follow-up, delivery outcome as well as follow-up up to 6 weeks of the cohort that gets enrolled within the first trimester. And the intent of the registry is basically to monitor the key mortality and morbidity indicators, including near miss, as well as we focus on some measures of healthcare as to how the system is functioning. I won't bore you with all these numbers, just to show that what is critical is the last row, the bottom row, where it shows we have nearly 100% follow-up both at delivery as well as at the 6-week postpartum period. Now, this is really of interest from epidemiological perspective in terms of what is happening in the community with respect to maternal and newborn health care. And if you look at some of the key mortality indicators, whether it is stillbirths, early neonatal deaths, or neonatal mortality, as well as maternal mortality, I don't think we are anywhere near what we were supposed to be in 2010. You remember, the MDG goals initially were set for 2010. They were nowhere near achieving it. So they pushed the target to 2015. The goal post to 2015, the targets remained the same. Even by 2015, none of the targets were achieved. And MDGs became SDGs, the Sustainable Development Goals. Even as of now, in 2020, we are nowhere near reaching the targets that we had set for 2010. A maternal mortality above 100 in a country which is trying to put people on the moon and sending space shuttles to the Mars is something that is not acceptable. A perinatal mortality around 45 per 1,000 births is again something which is unacceptable. If we can't guarantee a safe childbirth and a safe infancy to our children, no matter how much of advance we make in any other frontiers of science, this is something that we cannot be proud of. So this is something that really needs to be fixed, and fixed soon, if we really have to make a progress as a country. Even if you look at some of the morbidity indicators, low birth weight, almost 20% of the kids that are born are low birth weight. 10% of them are born preterm. That means remaining 10% are term IUGR, that is, they are growth restricted. So they are compromised even before they come into this world. So naturally, their subsequent development, subsequent maturity, and their evolution as a human being, as a productive person contributing to the national wealth, all become compromised even before they enter this world. Similarly, if you look at what is the nutritional status of our mothers, almost 90% of our women are anemic during pregnancy. That means they are compromised, the fetuses are compromised, and therefore the delivery gets compromised, and then subsequent growth and development also gets compromised. And if you look at the causes of mortality as well as some of these morbidity figures, most of them are from preventable causes. It's not as if we don't have any solutions. It's not as if we need rocket science to solve these problems. We have known solutions, but we are not able to take them to scale, or we are not able to take them to the community. So that is the context in which this whole presentation is based, in terms of what are the research protocols that we have implemented? What we have basically done is to test simple interventions that can be implemented in a community setting and make a larger impact on the mortality and morbidity numbers on a larger community base. So naturally, the research agenda is driven by the causes of maternal and newborn mortality and morbidity. So our work has been focused on trying to address postpartum hemorrhage, hypertensive disorders of pregnancy, maternal and infant nutrition. We are also doing some work in the area of cervical cancer, birth asphyxia, preterm birth, and early childhood neurodevelopment as they relate to the newborn issues. And we've also done some work in looking at the whole health system, in terms of emergency obstetric and newborn care, and how we can strengthen the health system to improve quality of care. I won't have time to describe everything that has happened in the last 19 years. So I've picked on a few examples of how the research has progressed over the last 19 years. We started out with this misoprostol, prostaglandin analog, which was actually marketed for the treatment of NSAID-induced ulcer by Searle in the late 1990s. And because of its uterotonic properties, so we thought it may be useful in prevention of postpartum hemorrhage. And the context you must understand, in 2000s, most of the women used to deliver at homes by either skilled, the ANMs or the auxiliary nurse midwives or TBAs. So if you're talking about oxytocin, it's a non-entity in these settings. You need a skilled provider. And number two, you need oxytocin to be in cold chain. If at all, it has to be effective as an agent for reducing postpartum blood loss. So we looked at misoprostol as an alternative to oxytocin. This was the first community-based randomized controlled trial of misoprostol for the prevention of postpartum hemorrhage. We got very encouraging results with very limited side effects. And therefore, it got incorporated in the guidelines of the Ministry of Health of the Government of India, the FIGO, ICM, the International Confederation of Midwives. It's now included in the WHO list of essential medicines and the UN life-saving commodities for women and children, as well as the drug has been registered for this indication in 26 countries. So a single simple trial which originated in a community setting had a huge public health impact. As part of that protocol, we developed a blood collection rate because, by and large, blood loss estimation is visual. And when we do visual estimation, we kind of tend to underestimate. So only when the woman shows signs of hypovolemic shock that the birth attendant or the healthcare provider begins to act. So we thought, why not have a calibrated device, a simple, sort of adapted Macintosh with a calibrated pouch to collect the, the blood loss. And WHO also started thinking, active management of third stage of labor has been advocated since the 1970s as a treatment or the management of the third stage. Has three components: uterotonic, control contraction, and uterine massage. But nobody had really evaluated as to whether or what is the relative contribution of each one of these in reducing postpartum blood loss. So we, as part of the WHO network, undertook a trial looking at the full Amstel package versus a simplified Amstel package that excluded control contraction. And basically what you see is, control contraction really doesn't add anything, if at all. When done by untrained, unskilled providers, it can actually cause uterine inversion and maybe even sudden death. So we thought ultimately what matters is a good quality uterotonic for reducing postpartum blood loss. Oxytocin remains the gold standard even today. Misoprostol, even though an alternative, it's an oral agent, can be easily administered, it is heat stable, but has certain side effects by virtue of being a prostaglandin, and especially in some of the hot climates, it can cause hyperpyrexia and some serious consequences to the mother. So basically the search for an ideal uterotonic that is heat stable, administered in most settings is what we are looking for. So in that context, the heat stable carbetocin came out as an alternative to oxytocin, because oxytocin requires cold chain storage. I mean, it has to be maintained at 8 degrees centigrade, and most institutions also, even academic medical institutions, do not maintain that cold chain, and therefore what women are getting is basically, either a placebo or a saline, whatever you may choose to call it, but they are definitely not getting oxytocin. So we need an heat stable product, and carbetocin, which is an oxytocin analog, was advocated as an alternative. So we participated in large multi-center trial spread across 10 countries and 22 hospitals that enrolled almost 30,000 women. And we had the privilege of hosting the trial steering committee meeting in Belgaum a couple of years ago, where the results were discussed and have been subsequently published in June of 2018. And what the study basically showed is that heat stable carbetocin is as good as oxytocin, and therefore in settings where cold chain cannot be maintained, it's a viable alternative to oxytocin. So we have 3 products now: oxytocin, the so-called gold standard; misoprostol, an oral preparation but with some side effects; carbetocin, which is heat stable but is an injectable. So we still are in search of a uterotonic that can be administered in community settings, even by less skilled providers, and that is as good as oxytocin, and that doesn't have the side effects of misoprostol. So even 20 years after our initial work in misoprostol, we still continue to search for the ideal uterotonic. Of course, the trial helped in amending or updating the WHO recommendations for the treatment, the management of postpartum hemorrhage. And because this was a new drug, a new formulation being tested, so this was almost implemented as a regulatory trial, and the pharmaceutical company, Ferring, which provided the drug, of course, they had no role in the trial per se. The trial was coordinated by WHO, independent of the pharmaceutical company. The pharmaceutical company had nothing to do with the trial per se, neither the protocol nor the implementation nor the analysis and the publication. But they have decided to manufacture it in India, and just 10 days ago, the pharmaceutical company has got approval from DCGI, and I'm really pleased that it's such a coincidence. The manufacturing facility is in Puducherry, so hopefully one day I will come down to see you all and visit that facility, because I have been working on this protocol for almost 6 years now. Second area that we have worked on is hypertensive disorders of pregnancy. Again, pregnancy hypertension has multiple sequelae. It causes reduced placental perfusion and therefore can cause growth restriction, can cause preterm birth, and hypertensive women are also likely to develop postpartum hemorrhage. So if you can fix this one condition, pregnancy hypertension, I think you can tackle multiple sequelae that arise out of that. So again, what we tried in this community-based study of CLIP, community level intervention for pre-eclampsia, is can we identify the women developing this pregnancy hypertension at the earliest and initiate treatment and bring them to a referral center for management. Now, in order to achieve early identification, we trained ASHA workers working in the community to measure blood loss, to measure proteinuria, and give them a mobile app to guide the management depending on the blood pressure reading and the proteinuria severity. Now, this was a cluster randomized control trial, and cluster randomized control trials have their own unique challenges. It's not easy to show a significant benefit in cluster RCTs unless the clusters are so wide apart and so well matched and so segregated that you maintain the fidelity of the intervention. So it's not easy, and so we did not show a significant difference between the control and the intervention clusters in terms of a reduction in mortality, but there was a trend. But more importantly, what we were able to show is that you can train even a lower level healthcare provider to do some minimal clinical monitoring of the pregnant women, identify the women as they develop hypertensive disorder during pregnancy, and then bring them to a referral center for treatment. Now, one offshoot of the study was, we were able to almost conclusively show that the only key diagnostic criteria for identifying preeclampsia is the systolic blood pressure. Proteinuria has really no role as part of the diagnosis of preeclampsia, and that is what the data coming out of the CLIP trial is showing, and got published just on the 1st of this month in the bulletin of WHO. The other issue as it relates to hypertensive disorders of pregnancy is, do we have a validated instrument for measurement of blood pressure? There are thousands of devices around, but none of them are validated for measurement of preeclampsia or for detection of preeclampsia in pregnancy. So our collaborators from King's College London partnered with Microlife to sort of develop and test a semi-automatic blood pressure monitoring device. You only need to inflate the cuff, and then it does the rest of the things. And what we have incorporated over the life of this evolution of this device is both ability to detect hypertensive disorders as well as hypotensive tension or shock or hemorrhagic shock, or rather hypovolemic shock. So it has, besides giving the display of the systolic, diastolic blood pressures and the pulse rate, it also has this, the traffic light signals. What you see on the lower right hand corner of the slide is that traffic light signal, the red, amber, and green. So both in terms of hypertensive disorder as well as hypotension or hypovolemic shock, it does alert as to whether the person is normal or getting into danger zone or is really at risk. So, and this is one of the innovations that fetched the Newton Prize from the UK Medical Research Council a couple of years ago as a novel innovation. So now we have a validated device, and we implemented it across almost 15 countries in Asia, Africa, and Central America, and we're able to show a significant reduction by just introducing this blood pressure device, that you can reduce some of the mortality and morbidity in pregnancy. And right now we are working on a protocol which is looking at early or planned early termination of preeclampsia. There's always a debate, whether the pregnancy should be, the woman should be stabilized in her blood pressure, and should the pregnancy continue, or should the pregnancy be terminated and then take care of the preterm newborn? There's always a debate. But the literature seems to be pointing in the direction of early termination of pregnancy and provide adequate newborn care or in NICU, so that you both save the mother and the baby. The third area is related to nutrition. If you recall, I gave you the figures for anemia. I mean, almost 90% of the women are anemic in pregnancy, and anemia is not something that develops just because a woman gets pregnant. So it's a condition that she is carrying into her pregnancy. So most of our current approaches are, trying to provide, whether it's iron or folate supplementation after the woman conceives or during the second trimester of pregnancy. That's what the current approach of the ministry and the RCH programs are. But if the woman is bringing this nutritional deficiency into the pregnancy, but why not intervene before she conceives? I mean, the pre-conception period. So we did a 3-arm trial. One arm receiving this micro and macronutrient mix made from peanut and soybean and dried milk powder. The basic focus is to provide enough calories as well as iron and zinc as two micronutrients of interest for growth and development. The second arm got the same nutritional supplement from 12 to 14 weeks of nutrition to match the current supplementation. And the third arm continued with the standard of care. And what we are able to show is that in both the preconception supplementation arm as well as the second arm, that supplementation during the second trimester of pregnancy onwards, we were able to show an improved growth and development of the fetus, the birth length being the primary outcome. We also looked at our own data from South Asia. There was also a site in Karachi, Pakistan, along with us. And we looked at this subset of the study, and we were able to, we see that, with this preconception supplementation, you can not only improve birth length, but can also reduce stunting and wasting. So therefore, we need strategies now to scale it up. How do we supplement the women with these key micronutrients, zinc and iron, especially in the preconception period, so that, if we correct her anemia before she conceives, and then she can have a safe childbirth as well as better pregnancy outcomes in terms of a well-developed baby. As part of that exercise, we looked at the whole, generic recipes of the region in terms of, what are these people eating, what are their nutrient values, what is missing, what is lacking, and what kind of supplementation is needed to optimize their pregnancy outcome. So that's been published. And right now we are almost about to start a trial looking at 2 intravenous preparations of iron for the treatment of pregnancy anemia, because the current approach of oral ferrous sulfate has never worked. We are one of the oldest countries in the world to start iron prophylaxis during pregnancy. It started way back in the 1950s. So 70 years down the line, we have absolutely no control on the rates of anemia in our pregnant population. So it has not worked. It's money down the drain. So we need alternative approaches to correction of anemia, and intravenous iron earlier had a lot of side effects, and therefore people were hesitant to use it. But the newer formulations like ferrous carboxymaltose and ferrous isomaltoside have overcome many of the serious adverse events associated with intravenous iron preparations. So they are safe. So we are now trying to see whether we can scale it up as a treatment option for the prevention of anemia during pregnancy. Another area that continues to be a challenge is how do we optimize the growth of low birth weight infants. Remember, I showed you figures of almost 20% being born low birth weight. So it's 1/5 of the babies that are born in our country. So how do we optimize their growth and development? Breastfeeding alone is not enough to take care of these low birth weight preterm infants. So will formula be needed? Will supplementation work, or will fortification work, or the newer initiative, human milk bank? And we have one in our hospital that has started functioning last year. So can donor human milk be an alternative to promote optimal feeding? And again, donor human milk, again, requirement of each baby, like personalized medicine. I mean, these are all the issues that are begging an answer. And we're right now doing an exploratory study, and hopefully we should be able to develop a trial in the next 1 or 2 years addressing some of these issues. The other major area that we have worked in, as far as it relates to newborn care, is the management of birth asphyxia. And we started this work somewhere in 2005, and till that time, there was really no training of the birth attendants working in the community, whether it is ANMs or, and of course, in those days, TBAs, for the management of birth asphyxia. So this was the first time that any attempt was made to train traditional birth attendants and ANMs for newborn resuscitation using a bag and mask. I just adore this picture, a 60, 70-year-old traditional birth attendant, who has never counted in her life, learning to do Apgar scoring and using bag and mask ventilation, and saving lives. I mean, if anything, in the last 20 years, this has been probably the most enlightening and most revealing moment of my life in the whole MNH research. That, there's no bar to learning and there's no limit to learning. And these ANMs and the TBAs who did fantastic work, drew worldwide attention, as much as the US Secretary of Health flew down specially to Belgaum to meet these TBAs and personally interact with them and find out what their experiences were. So from that initial experiment, and there was also concern, okay, you give them all this, bag and mask ventilation, train them, are we going to end up with all these hypoxic babies with compromised neurodevelopment? So we did follow these cohort up to 12 months, and fortunately, we didn't find any evidence of neurological impairment in the babies who were resuscitated and who were saved. So the final conclusion was that it can be rolled out. It can be a community initiative. So the AAP ended up modifying its neonatal resuscitation program and developed Helping Babies Breathe curriculum. We were one of the sites to validate it, and of course subsequently got incorporated in the NSSK, or the Navjat Shisha Suraksha कार्यक्रम of the Government of India. The other major area that we have worked in relates to the preterm birth, and one of them being the whole issue of the use of corticosteroids in the antenatal period for to promote fetal lung maturity and thereby reduce mortality among preterm babies. And again, this is an intervention that has been around since the 1970s. But even till recently, there has not been much uptake even in academic medical centers in terms of its use. So what the global network thought is, all right, can we scale it up? We're not questioning whether the antenatal corticosteroids will work or not. We thought it will work. So what we are trying to do is, can we take it down to the community? Can we train, again, ASHA workers and ANMs to identify women who are at risk of preterm birth with simple symptomatic identification, bring them to a primary health center or referral center for the administration of the corticosteroid. Yes, we were able to improve the coverage, but what we found shockingly was, A, there was no benefit in the preterm births in terms of reduction in mortality. This was a placebo-controlled exercise. In the cluster that received the antenatal corticosteroid and those which did not, there was no difference in the mortality rate. But what was really shocking was that the mothers who had received the corticosteroid in anticipation of a preterm birth, but who ended up continuing their pregnancy to term. So the babies who were born to these women had a higher mortality. And the only signal that we were able to pick up from the database was that there was an increase in the rates of maternal infection in the intervention group. Now that set sort of alarm bells going in WHO, because they're almost on the verge of rolling antenatal corticosteroid as a community level intervention. So they said, wait, there's something more to this story than a simple rollout. So they said, okay, it should be used with caution in certain settings until it is evaluated in a larger trial. And that is how this whole Action 1 and Action 2. The Action 1 is the use of antenatal corticosteroid in early preterm, 28 to 34 weeks of gestation, and the late preterm is 34 to 36 weeks of gestation. You may wonder as to why this distinction between early and late preterm. The early preterm is trying to show efficacy in terms of reducing mortality. The late preterm, if you recall from the ACT results, is there harm? The increased mortality that we had seen in the term babies. And some of the morbidity that is associated with the use of steroids in the late preterm period, like neonatal hypoglycemia. So we just completed the trial. The primary paper out of the Action 1 trial has been accepted in the New England Journal of Medicine. So stay tuned. It should be out in the next couple of weeks. Again, significant results that are bearing for public health interventions for reducing mortality from preterm births. But we could not, for some logistical reasons, complete the late preterm trial, the Action 2 trial. And in the meanwhile, new evidence came showing that maybe the dose of dexamethasone that is currently being used is on a higher side, and therefore we may look at a lower dose corticosteroid administration without losing efficacy, but at the same time reducing the harm or the morbidity. So we are right now working on this protocol, which will compare the standard dexamethasone regime versus a low-dose betamethasone regime, which is shown to have a better effect on fetal lung maturity with these side effects. So that's the Action 3 trial. So I've basically lived and breathed this corticosteroid story for almost 15 years now. We started working on this somewhere in 2005, and again, we still have unanswered questions. Now, what I'm trying to show here is, we test simple interventions, we think that they will work, but in real world settings, now the results are not always what you expect. Sometimes they do, sometimes they don't. But research to search for options or interventions that can reduce the major killers of babies and mothers have to be found and have to be found soon if we have to reach the SDG goals. This is sort of the last study that I'll discuss with you right today. One of the, given that hypertensive disorders contribute to significant morbidity and mortality, and the placental perfusion being one of the key factors, so why not use aspirin, low-dose aspirin during pregnancy and see whether it can reduce preterm births, was the question. So the global network completed a large community-based randomized controlled trial of low-dose aspirin compared to placebo. We enrolled almost 12,000 and we restricted to nulliparous women because, in recurrent preterm birth, probably the causative factors and maybe some of the treatment options available for preventing recurrent preterm birth. So we're basically focusing on the nulliparous population. So we enrolled almost 12,000 women across the 7 global network sites, 2,700 coming from Belgaum itself. And we were able to show a significant reduction in preterm birth as well as pregnancy hypertension in the preterm pregnancy hypertension. Again, not a very novel drug. It's not a new drug. Aspirin has been around for centuries, but a new indication and a new outcome that we are hoping for. And we are just about completing a study. So basically, we really need to understand what causes these deaths, what causes the preterm births and what causes stillbirths. And unless we know for sure what causes, you can't intervene. So we are just about completing a descriptive study looking at stillbirths and preterm neonatal deaths, trying to understand the causative factors, including the biochemical markers, the histopathology, the placental morphology, as well as the whole infectious disease profile as it relates to bacteria, viruses, fungi, almost 70, 80 odd organisms. We are running a RT-PCR to identify whether there is an infectious pathology to stillbirths and preterm neonatal deaths. And as part of that exercise, we've also been comparing, full-blown autopsy of these newborn fetuses versus a new technique promoted by a group in Barcelona called MITS, or minimally invasive tissue sampling, as an alternative to full-blown fetal autopsies. We should have some very interesting results coming out of this study next year. Again, stay tuned for some major publications coming out of this project. Another area which is pregnancy is not new, labor is not new, but our understanding of the the whole delivery process and our effort to identify predictors of poor pregnancy outcome still continues. So we are just starting this study next month, looking at the whole process of labor from the time of admission till discharge of the mother and the baby. Again, looking at fetal monitoring through sensors connected to remote servers, biochemical markers, sonography, and so basically trying to put everything together into a machine learning algorithm and come up with predictive models which can predict poor pregnancy outcomes, and based on that develop interventions to reduce those poor pregnancy outcomes. I don't know what I did. Okay. we also just started, in fact, last month, we started recruitment to a large, again, a community-based study, community and facility-based study of a single oral dose of azithromycin, 2 grams, administered to women just before labor, and see whether that can be protective against the development of neonatal sepsis in the first few weeks of life. COVID and pregnancy, is another area. I mean, as with COVID in any area, is a new territory that needs to be charted. And since our focus is on maternal and newborn health, so we have a couple of protocols, one from WHO and the other one from the NICHD Global Network, looking at the association between positivity with for COVID and pregnancy outcomes, including maternal, mother to newborn transmission, etc. So these are studies that are just about to go into the field. So we're also trying to be contemporary in terms of the common problems affecting mothers and children. And although I'm sort of the figurehead, there's a whole team that works day and night with me, right from the community health workers, the ASHA, the ANM, the medical officers, facility staff, and my own colleagues. We work in Karnataka, Maharashtra, Odisha, and shortly in Rajasthan. Hopefully, we would love to partner with your institute in Puducherry as well in the coming years if the opportunities arise. And none of this would have been possible without the the support and the collaboration that we have had with both international and national institutes. And we have lived and worked on this for almost 20 years now, and I think it's been a truly rewarding journey, in terms of trying to find some simple solutions for saving the lives of mothers and newborns. Of course, all this needs money, and we have been fortunate to get the sponsorship from a host of funding agencies, and I must express my sincere thanks to them for the trust and the faith that in our unit, and we this whatever little work that we have done in the last 20 years in the coming years as well. It was a very long presentation, and I'm sorry I might have exceeded my time. I tried to compress almost in that way. Once again, thanks to Dr. Mahalakshmi, and of course my friend, colleague, and a buddy in a way, Professor Kotur, for this wonderful opportunity to share some of my experience. I mean, so thank you so much. Yeah, over to Dr. Mahalakshmi, please.
Yeah. So thank you. Mind-boggling is the word I comes to my mind, because from very simple, humble beginnings, you are indeed a big inspiration for people taking up research. And when we keep talking about research, the common complaint which many of the young researchers say, right, is that when we ask them what is your follow-up rate or your attrition rate, then if you can achieve something about 60%, 65% follow-up itself, it is considered extremely good. And with your team, you have consistently shown more than 98, 99% follow-up. I think that is hats off to your teamwork, sir. I think that shows that how good is your commitment or connect with the community. So that was something which was very inspirational for all of us to take the message. And doing community-based trials is much more difficult than trying to do hospital-based studies or diagnostic studies. So when you can show that, that sets the standards for us to look upon and then see how much we can go. That apart, I had some observation, some questions also to use it. One is when we showed the figures, you compared across Kenya, our centers from Bangladesh, and then also from Karachi and other things. Like what was very striking was even though countries like Sri Lanka and Bangladesh and all were much below us at some point of time, but now they are doing much, much better. And their rates, I saw one very peculiar statistics. Their low birth weight rates are much higher than us, but their mortalities are much, much lower than us. So can you please explain what they are doing it right or what they have done right to get into this level? Because that is something which we need to learn from our public health perspective, I think. So.
Yeah, thank you. And yeah, that's a very relevant question. And in fact, I will discuss another study that we had implemented, the emergency obstetric and newborn care package, which was both a community and facility-based intervention. Training birth attendants, community sensitization or community mobilization, and ensuring quality of care at the facilities. I think that, and they also looked at the trends over time in the maternal newborn health registry. As I said, it is from 2008 onwards. So we, in fact, a few publications are in the pipeline. Hopefully by November in reproductive health, there's one full supplement from the maternal newborn health registry, almost 19 papers looking at various parameters as to what is happening over a period of time. I think the lesson from all of that is you can improve antenatal care. You can improve, early recognition of the condition. But when a woman shows up for delivery, if she doesn't get timely treatment and quality treatment, you cannot save lives. So the whole focus, again, if you look at, stillbirths, the 7-day neonatal mortality and the 28-day mortality. The 7-day mortality is around 20, and neonatal the stillbirth rate is also 20, so 40 there. The late neonatal mortality from day 8 to 28 is only 5 per 1,000. That means most of the deaths are peripartum, intrapartum or peripartum in the first week of life. Postpartum hemorrhage as it relates to mothers, hypertensive disorders of pregnancy as it relates to mothers, or birth asphyxia, preterm. So there are interventions that are known. There are things that can be done around pregnancy and childbirth, but the quality of care is not adequate enough, is not evidence-based. So still all kinds of practices go on in the labor rooms. Even in good facilities, in secondary care, tertiary care facilities. So the whole thing revolves around ensuring quality of care for the mothers and the babies. Unless we fix that, you can bring the women to the facility, but unless you improve the quality of care in the facility, you're not going to achieve reduction in mortality. So that's sort of the underlying undercurrent in all this.
That's very nice, sir. Actually, as they're saying in medical education course, no?
That is where, and that is where most of these countries, like what Sri Lanka is able to achieve, what even Bangladesh is able to achieve, Nepal is able to achieve. Of course, we are a much larger country, without doubt, but we also have much more resources than them. But we are not able to deliver to the people who need it. So there is that gap.
Yeah, sir. So that's what most important thing when we keep teaching a lot of hi-fi stuff like recent advances and stuff like that to this. But the most important determinant of quality of care is basic competence and basic following protocols. So that's the lesson what we need to take. Other thing which was very striking from your presentation also, like I really like the saying by Einstein, who says that make things simple but not simpler. You showed us very elegant solutions in your research, like be it measurements for using drapes to collect the blood loss, or using automated with traffic cone signs, traffic light signs for blood pressure, or using a mobile app for the ASHA workers. Very elegant, simple, meaningful kind of solutions. So, but in the process, you also said something about you did a lot of strengthening of health system research. So, can you a little bit elaborate on it, sir? I don't think that much of it came in the talk, because I think for want of time and others.
I know I didn't get into much of that. Ultimately, what there are two things that are infrastructure in terms of the minimum support services, whether it is in terms of availability of C-section, availability of blood transfusion, newborn resuscitation, warmers, ventilators, or CPAP machine, basic thermal care, feeding, management of the airway. So one is the infrastructure part, and infrastructure-wise, you walk into any taluka or the sub-district hospital or a district hospital, you will find equipment lying there, idle, unused places. We have staff, but who are not well equipped, who are not well versed, who are not trained. I make the contrast between the TBA training that we did in first breath, for newborn resuscitation with bag and mask. If a 60, 70-year-old lady can learn APGAR scoring, who has never counted in her life, and fill out a pictorial data form and do bag and mask resuscitation and save lives, why we can't achieve the same with much younger, better qualified, quote unquote, healthcare providers. So there is a barrier in terms of attitude, approach, practice, and being competent or proficient. I mean, we are talking about, competency-based medical curriculum. I think competency-based health professional education is what is needed, I think, across the board, whether it is nursing or whether it is paramedics or whether it is a doctor. I think we have really not given much focus and much attention to this skill development during the undergraduate and postgraduate training. And it's ultimately a reflection of how, what kind of graduates we are giving to the community. What is their quality, what is their competence, what is their level of skills, as they get out of the portals of the medical colleges or the nursing schools or the, the physiotherapy schools, whatever. I think that is where, the onus really lies in medical education and medical educators, or health professions educators to, really train and bring out competent healthcare providers.
Yeah, that is well said, sir. The basis of competency-based education and training should be the societal needs, which dictates what competencies we should achieve, rather than the what the professionals think that they need to impart to the students. So that was good. I go over to Dr. Kotur. Sir, do you want to ask anything or say something, sir, to your friend and your buddy?
Yeah.
Okay, nothing new, because I have been with him for many of first-hand experience of that. It is not a wonderful, Dr. Shiva. The explicit presentations that gave your first-hand experiences, and the clear message is, for all the aspirant researchers or the students or even the staff members, is if there is a will, there is a way. They always say that. We remember way back in 84, 85, we were all juniors, and I was in anesthesia, you were in physiology, and and how slowly we medical education, and we whatever we wanted, we started doing that with our commitment. You can certainly, you are an example, I said, and again I feel happy to say that you are indeed a phenomenon, Dr. In the words of that African lady, which I feel proud to tell all the time. Yeah,
Okay.
Thank you, sir.
Yeah, and one good thing you said is you showed a ray of hope that the company which has taken the responsibility of producing the carbetocin is located here in Puducherry. Certainly, I hope to be here for some time, and okay, I will have you here. Okay.
Before you leave, I'll try.
Okay. Thank you very much. Yeah. Thank you, Mahalakshmi.
Thank you, sir.
Yeah.
Thank you. On that bohemian note, we'll stop this today's session, and we should thank Dr. Shivaprasad Goudar, who did a fantastic thing. And just one thing I want to share from the chat box. Actually, there's one message from Dr. Naburan Karamkar, who's working in the Department of Community Medicine in Tirupura Medical College, Agartala. So he has thanked you extensively for such a wonderful session. It just shows that how much is the reach of this program and the platform we have created. So on behalf of AVMC, Vinayaka Missions Medical College and the Scientific Society, I thank Professor Goudar for an interesting, scintillating and stimulating lecture, and for taking time to share his experiences, rather I would say his journey through the field of maternal and child health over the last 20 years. And he said, as he said, no, he has lived and breathed, and he has lived with this trials and with these pregnant women trying outcomes. Thank you very much, sir, for participating in this session.
Yeah, thank you. Thank you so much.
Thank
Bye-bye.
you. Thank you.
Yeah.
Bye-bye.
Yeah, and there are some announcements for the participants. One is your e-certificates link will be sent to you through messaging, so you can actually download your e-certificates. The second thing is for the next week will be our Silver Jubilee episode, that is episode number 25. So we are in with a very big surprise for you. Please stay tuned. We'll keep sending you updates on that because we are trying to get a very nice speaker for the other session, and we'll let you know by shortly. So that is all I have to say from the MC's desk today. So on behalf of the Scientific Society, I bid you all good evening, and thank you very much for attending this session. Please stay tuned. We'll see you next week on Friday again at 2:45 p.m. Bye bye, folks. Take care during COVID. Thank you.